The Center for Disease Control is supposed to give new guidance when it comes to masking tomorrow. Tonight, as she always does, we are joined by Dr. Ruth Berggren from the Long School of Medicine at UT Health San Antonio, an infectious disease specialist. Thank you so much for being with us, Dr. Berggren. And right off the top, I want to talk about that guidance. It's expected that they're going to allow people to not wear masks in some indoor settings. Is that kind of what you're hearing as well?
Yes, indeed, but that hasn't translated yet to my workplace. And of course, I work in a hospital and a clinical setting, so healthcare workers are going to continue to be masking. But overall, if we look at what's happening in San Antonio, we are now down to less than a 10% community positivity rate. And the case rate per 100,000 has dropped significantly from where it's been to 23 per 100,000. So we are certainly in a zone where we don't have high community transmission evidence. So I think this will be welcome news for a lot of people. I will caution you that wearing a mask is a good idea. I'm still seeing cases of people that are being diagnosed by home COVID tests, and they're fortunately able to get treatment from their primary care doctors with antiviral medications. So we're not even seeing them in the hospital. So it's not like it's gone. But the rates of community positivity and overall case rate is way down.
Before we move on from masks, I want to ask you, I heard somebody on the radio today talking about how they think moving forward, masks will be sort of like raincoats. Like when there's surges, we'll put on the masks. When there's not, we can put them away in the closet. I mean, is that kind of how you're seeing it as we move forward here?
I certainly think that people should be aware of their community positivity and their case rates in thinking about that. And also to be thoughtful about whether you're vaccinated or unvaccinated if you're deciding to take your mask off and go into a crowded indoor place. Unvaccinated people, beware.
And speaking of vaccines, some new guidance on the timing between your first dose and second dose of the mRNA vaccine. Can you explain that?
Yeah, so it used to be that it was 21 or 28 days after between your first and second Pfizer or Moderna dose. And now it looks like waiting longer, waiting 8 weeks before your second dose is a better schedule because it seems to create more robust and more lasting immunity. So as we continue to do throughout this pandemic, we're learning. And these guidelines change not because people are crazy or they can't make up their minds. These kinds of guidelines change because we scrutinize the data that we're collecting. And as we look at that data, we learn how to do things better.
We continue to learn. When we talk about the vaccine, a lot of people are already wondering about the fourth shot. If they should get it, who should get it, when they should get it, those kind of things.
At this moment, the only people recommended for that fourth shot are really immunocompromised folks. And that means people that have had solid organ or bone marrow transplants, people that are actively undergoing chemotherapy, people who have advanced AIDS. Those kinds of people are advised to get a 3-shot first series and then a booster. So those people would get a total of 4 shots. Whether the rest of us who don't have those issues are going to need another shot is still to be determined. I anticipate it is in our futures, but I'm not recommending outside of guidelines that people go and get a 4th shot just because it's been 5 or 6 months since they had their 3rd shot. We need to wait. It may be that the next shot that's recommended will have a different composition, that it will be modified to be targeted towards the variants that are circulating.
You know, we spent a lot of time at one point talking about monoclonal antibody infusions. We learned that cetrovamab was less effective with this Omicron variant. We're seeing more variants of Omicron. So is that still the case? Is that still not being used as much?
Yes, so we actually are continuing to give cetrovamab in our community. The subvariant of Omicron called the BA2 is not something that we're seeing here. And so we're pretty confident that it's not greater than 80%. There is a guideline out there that says that if your community has more than 80% of the BA2 Omicron subvariant in circulation, that in that case, it's not worth giving the cetrovamab, and people should be directed to other kinds of therapy, such as the antiviral Paxlovid, which has an 87% reduction in the need for hospitalization or serious progression of illness.
You rounded in the hospital earlier today. Can you talk about what you are seeing there or what your colleagues are seeing in terms of patients who are hospitalized with COVID right now?
Right. So I'm on a general infectious disease service. And so people are coming in for all different sorts of infections, from diabetic feet to bloodstream infections with Staph aureus. And what we're seeing is we're finding COVID in folks that are coming in for other things. That's one type of COVID-19 patient we're seeing. And we are seeing, as recently as this weekend, someone who came in with pneumonia. And after they were here for 2 days, we were able to document that the pneumonia was actually due to COVID-19 and not something else. So people don't think that it has truly gone away. It's not gone. And some people are needing hospital admission for it. It's just not nearly in the same numbers as we had been seeing previously in January.
Dr. Ruth Berggren, Long School of Medicine at UT Health San Antonio. Always appreciate your time.
Thank you.
We'll see you next time, and we'll be right back.